setting up a cardiopulmonary rehabilitation unit and making it a success. So cardiopulmonary rehabilitation not necessarily mean it is only for the cardiac patients. For anybody who wants to prevent a cardiopulmonary disease, it becomes important. So the one of the great thing I could achieve is that I got automatic referrals for all the patients who are undergoing a CABG in Apollo Greaves Road, Chennai. And their numbers are huge. They are doing like 150 cardiac surgeries in a month. And I get to see all those patients automatically. The conversion to a rehab program depends on the strength of recommendation by the primary treating physician though. So today's discussion, I will focus on the basics of the principles of cardiopulmonary rehabilitation so that you are clear on what to do and be clear about and confident about setting up your own center. So that is the whole point of today's discussion. So my experience in Australia was in an inpatient elderly care unit, where we used to do inpatient cardiopulmonary rehab as well. So outpatient rehab is mostly done by nurses along with the cardiologist. That is post heart problems. Any patient going home will have an automatic referral for a cardiopulmonary rehab program. But those who are very sick and not able to go home will get transferred to a rehab center where until they are totally independent, they spend the time there. That is how I got exposure in the cardiac rehab as such. Good. So when you look at the historical context of cardiac rehab, so initially before 1950s, people was very scared to do cardiac rehab, and heart attack survivors were put to bed rest for 6 weeks, sometime up to 1 year, fearing that they will die if we try to mobilize them. So leading to deconditioning and the need for a rehabilitation later on. So this was the history, how it all started. In 1960s, somebody called Levine and Lewitt came up with a bold effort to mobilize these patients out to an armed chair. They call it an armed chair research. So where they just mobilized these patients and made them sit in an armed chair. They could see that this definitely improved their outcome, their quality of life, and the survival rate improved. That was the turning point in the history. So from 1970s onwards, the cardiac rehab programs started to be to get established all over the world, especially in developed countries. And it used to be multidisciplinary program. Can you hear me?
Yes.
So it used to be multidisciplinary program and a 3-month program. Then there was this Framingham Heart study, which recommended inclusion of secondary prevention measures into the cardiac rehab program as well. So it was not just exercise, it was included diet and psychosocial well-being as well, and in addition to the secondary prevention measures. So there was as we progress through the 2000 and latest, after this COVID breakthrough, there was a sudden switch in the concept, saying that we can also opt for the telemodels. Telemodels started picking up because it improved access. Worldwide, even though there was automatic reference for the program, the uptake was less than 10%. Those with cardiac conditions would not enroll into the program for whatever reason. So less than 10% was the uptake. So after the COVID-19 pandemic era, there was a switch to this inclusion of telemodels into it. And this resulted in better uptake by the patients. So what is the level of evidence? So actually, this is a presentation I made for the cardiologist and the surgeons in our hospital. So as to push them to accept the program. So the level of evidence is very important when you try to convince people. So level 1A evidence, it's strong. You can read through it. This is the slide I've taken from the AHA recommendation. Strongly recommended, high level of evidence, benefit outweigh risk. It should be performed, recommended, indicated, useful. All these terminologies they are using. So that means it's as effective as the medications they are prescribing. So it should be prescribed along with the medications. So because that much importance is given for it abroad. So in Canada, I met with a patient who had undergone cardiac surgery in Canada. So after cardiac surgery, unless the patient enrolls into a cardiac rehab program, they are not allowed to get back to work. So that much importance is given. So this is a this is a Million Hearts project by the US CDC US. 36 hours sessions. There is an organization called American Association of Cardiovascular and Pulmonary Rehab. It is their guidelines that we usually follow. So what their recommendation is, 36 one-hour sessions. So it includes supervised exercise, patient counseling regarding the psychosocial well-being, and also the nutritional education. All this together, they have the studies have proven that individuals who attend 36 sessions have 47% lower risk of death and 31% lower risk of having another heart attack compared to those who attend only one session. So one session, so currently what I am doing in Apollo is this one session I provide automatically. So you are following me, no? Hello, can you hear me?
Yes.
Oh, sorry. So this one session, I before discharge, I go and see the patients and provide them all the secondary prevention advices and recommend them coming as either OP or taking up a tele rehab program so that they can get the full benefit of 36 one-hour sessions. So they say even though it seems to be costly, it saves the money later on by preventing readmissions and hospitalizations and whatever medical expense in future. And they recommend these methods to improve the uptake of the program. Automatic referral system, systematic referral at the time of discharge can help the eligible patients to connect with the programs. Strong coordination should be there among the inpatient, outpatient rehab referral programs. So what we do is after they get discharged, we follow them up through phone calls and recommend them to come in and enroll in the program. So the patients, whatever we do, but only if the primary treating doctor strongly recommends the program, then only the patient is taking up the program. That is one thing that we usually notice. So only if the primary says that you need to go and enroll in the program and then you will get a lot of benefit, then only the patient is coming to and enrolling for the full program though. So in US also, even though the program is completely free, only 10% of the eligible patients with heart failure get referred, and among that, less than 3% was getting enrolled. So what is the state of India? So India, somebody from US did a online audit on regarding the number of centers in India. So this was the study. Only 23 centers responded, and it was a phone-in interview. And their criteria was that the centers which are doing a multidisciplinary rehab program. They should have just a physiotherapy program. It should be multidisciplinary, including the rehab nurse, rehab nutritionist and psychologist. So 23 centers for a 1 billion population. So again, in that 23, there was only one center which was taking care of the patients with pulmonary hypertension and all. So as the complexity increases, the number of centers offering cardiac rehab comes down. This was done in 2017. So this is part of the WHO's screening for the Rehab 2030 goal. So who is eligible? Ideal cardiac rehab. When you say about cardiac rehab specifically, these are the eligible candidates. Post acute myocardial infarction, post CABG or percutaneous intervention, heart valve repair or replacement, or heart and lung transplant. These are the primary qualifying events, and even those with chronic stable angina gets qualified. So we usually during the 6-minute walk test for the chronic stable angina patients, we look for the limit of their heart rate at which the angina symptoms get precipitated, and we try to keep the target heart rate for training 10 counts below the target heart rate, below the angina threshold. So systolic heart failure. Heart failure is one of the major chunk of our patients, because heart failure cardiologists are quite supportive to, in Apollo, and they usually refer if all the possible candidates to me. Heart failure is the one major area when we as rehab physicians get to see the most of the improvement after the patients start attending the program. I have had patients with right heart failure as well as left heart failure, and for one of the patients, actually the right heart function improved from severe to moderate to severe to mild. So that much improvement we could bring in. Uh, and the diagnosis based, whatever big surgeries is done, post that, if post a long ICU stay, if the patient is deconditioned, they can always come in for an inpatient rehab program. So these usual cardiac rehab programs are done as outpatient program. If they're not well enough to get discharged home, then it can be done as inpatient also, where they need more medical monitoring and the need for a rehab physician. So it could be the latest advances is the ventricular assistive device, where it's a transplant thing, where the patient carries their heart in a bag. It's like a pump which the patient carries along till it acts as a bridge for the transplant surgery. So that those are all advanced things. And pacemaker, even after pacemaker insertion, if they are struggling with the independence, we can see them. So it is, as I said, if when you talk about cardiac rehab, it's not just about exercise. That is one of the main thing I would like to highlight. So it includes exercise, nutrition, psychosocial management, and other risk factor control. So main risk factors, as you know, there are 10 risk factors in which 3 are non-modifiable and 7 are modifiable when it comes to cardiac problem. So exercise, in each of these domains, the patient is supposed to set goals, and the therapist is supposed to plan the interventions. What are the goals that I would like to achieve in this 3 months? And the education. It should not be just an exercise program and the patient going back home. There should be education sessions. So what we do is we conduct online meetings through Microsoft Teams, so that the patient need not come to our hospital for that education session. So weekly once we conduct this education program, which is part of the package. So nutrition also, there should be goals, interventions, and education. So all this program, they should have outcome measures. That is one of the main factors in that previous study I mentioned. It should be multidisciplinary. It should have standardized outcome measures, and it should be medically supervised. So these are the criteria for a good rehab program. So psychosocial management includes the psychologists getting involved into the program, and they should also be able to do a screening for depression. Depression is quite common after any cardiac condition, and it's very important that patients get screened for depression. And another thing that they do is motivational interviewing. So all these factors are just lifestyle modifications. Somebody need to change the way they were living until now. So for the change to happen, there should be enough motivation. So that there's a specific thing called motivational interviewing that people do for that. So other risk factors, that is the main area. So tobacco cessation. Tobacco cessation clinics should ideally be there. And medication compliance is another main thing that we touch base upon. We are supposed to educate the patients on what the role of each and every medicine is and what are the potential side effects, and how to when to reach out to doctor when the side effects happen. All this we educate the patient. So, for example, if we are using dapagliflozin, there is high risk for a urinary tract infection, and we need to teach them that you need to be doing good perineal hygiene to prevent it. If they are on spironolactone, their potassium level need to be monitored. Depending on the weight, the medicines need to be adjusted in heart failure patient. So, diabetes is another main. Most of our, almost 90% of the our patients that we screen will be diabetic. So controlling diabetes, how to do it is one of the major advices that we give. How to keep the, how much should be your target HbA1c, and how are you supposed to monitor diabetes at home, and when to reach out to the doctor. So heart failure, when it comes to heart failure, one of the major things that we usually struggle with is the fluid restriction. Unless the patient is on adequate fluid restriction and volume overload control, we struggle to make them exercise. So when they exercise, the heart rate goes up like anything like 130, 140 if they are in a fluid overload status. So unless you prepare the patient well, along with the diuretics, we need to make sure that the patient is compliant with the fluid restriction. So that is one thing, and optimizing the diuretics so that when they stand up, the BP is not dropping and we are not able to proceed with rehab, then we need to call the cardiologist and talk to them to please adjust some of the medicine so that we can proceed with the rehab program. And also monitoring for arrhythmias. So heart failure patients, they need to have one-to-one supervised sessions ideally. At least the first few sessions should be ECG monitored. These patients can have arrhythmias precipitated during our rehab program. So it gives us as well as the patient so much confidence if we just put the ECG leads on and monitor it with the just a defib machine we are using to monitor. So our physiotherapy unit already had the crash cart, and just using that crash defib machine from the crash cart to monitor the ECG. I didn't order for any of the hi-fi machines. I just utilized the existing cycle, treadmill, and the defib machine from the crash cart for exercise. So blood pressure control, the target is below 130/80. Cholesterol control, LDL, if it's a male, the target should be above 40, HDL above 40, and it's a female, HDL should be above 50. LDL we would after a cardiac event, we would target it below 70. And if it's a patient who had a high risk factor, high risk for a repeated event, we would target the LDL even below 55. So educating all these values to the patient, so that when they do the next blood test, they are more clear about what their targets are. Triglyceride below 150. All this we advise and make sure they're clear before they get discharged. And cardiac pulmonary rehab is also happening, in which we see the long-standing lung conditions like COPD, bronchiectasis, ILD, and we work in close coordination with the referring team and update our concerns regularly. So it is a bit risky. It is not as easy as neuro rehab, I would say, because cardiac conditions won't give you the time that a neuro patient gives. Patient can suddenly collapse, and it can. The first question, I had a patient who with whom I did a 6-minute walk test after PCI, and he after the 6-minute walk test he had chest pain. So the first question the family asked me, "Are you supposed to do this test? Are you a cardiologist?" So that questions we should expect. So we should play safe and empower ourselves with enough knowledge before we start this. So that is very important, and closely coordinate with the referring team. So cardiologists and pulmonologists will always be there to back you up. So ensuring that their backup is there and you are knowledgeable enough and you are good enough to convince the patient that it is okay, and it didn't show up any ECG changes, and as long as you are fine, it's okay. So what your target heart rate is usually what we look at. So somebody did a study in the heart failure patients to know the effects of cardiopulmonary rehab on different organ systems. So cardiopulmonary rehabilitation is not just exercise. Usually, some of the cardiologists confuse that patients are not supposed to do strengthening if they have a cardiac illness. That's an old concept. It has changed. They can do strengthening, but any exercise that involves holding their breath and straining will cause extra strain on the heart. So it's all patient dependent. The individualized treatment plan is the main key point. It should be individualized based on the each and every patient. So aerobic exercise is a major part of the program, because that is the one thing that increases the heart rate. Strengthening is very essential because it even changes the muscle fiber type. So strengthening will improve the fiber's ability to extract oxygen and also help the patient to do this aerobic exercise in a better manner. So along with this exercises, there is definitely this dietary interventions that's important. Diet, the fermented food, which reduces the inflammation, along with the fiber-rich diet, low-fat diet, and the risk factor control, controlling their diabetes, hypertension, cholesterol, and any additional risk factors like tobacco cessation if they have, and the time for which they exercise, and the duration of the rehab program. If they do it for the full 3 months, it's better. So these are the effects that they could see: improved cardiac output, reduced filling pressures, and reduced resting heart rate. We see this all the time. Once the patient enrolls into our program, we see that their heart rate nicely comes down. Even if it's a heart failure patient, we see the results in 1 or 2 sessions itself. So their resting heart rate nicely comes down and settles at a point. So we also encourage them to monitor their weight if it's a heart failure patient. Daily weight monitoring is very important. So autonomic balance improves, reduced sympathetic tone and improved vagal tone. So vagal tone is what we want to improve. So that is happening. And all this hormonal changes happen. Reduced renin, improved renin-angiotensin mechanism. This is the level at which even the BP medicines act, the AC inhibitors and the ARB. This is the point at which those medicines also act. You can see the same effect you get through the cardiac rehab program also. Reduced inflammation and inflammatory cytokines. They say that the autoimmune reactions come down, autoimmune markers come down, inflammatory markers come down, and the tumor necrosis factor improves. There is more resistance against tumor. At the same time, there is protection against autoimmune disease. And this inflammation is the primary cause for the heart problem. So the first thing that happens in a blood, the coronary artery disease, is the inflammation of the lining endothelium. So once the lining endothelium is inflamed, then it becomes leaky and the cholesterol gets inside. So that is how a cardiac problem develops. So preventing inflammation is extremely important when it comes to prevention of a cardiopulmonary disease. So insulin resistance reduces. So this is another thing that we often see. So once the patients enroll into any kind of exercise programs, their sugar levels get under better control. We often advise them to monitor their sugars at home so that they are at risk for hypoglycemia with the existing insulin dose. So often we find that when they are exercising properly, their sugar levels get under good control, and we'll have to advise them to bring down the level of insulin. And once they are non-compliant with the exercise, it rebounds. So that is also there. Once they get out of the program, and if they're lax and not following up the rehab program properly, the sugar levels might spike again, and we encourage them to be compliant and maintain the properly. We do over the phone follow-ups for 6 months. And when it comes to muscle, as I said, improved oxygen extraction by the muscle fiber itself. Even at the mitochondrial level, changes are happening. The mitochondrial enzymes are changing so that this aerobic, anaerobic, this thing, no? So it improves the oxygen extraction capacity of the muscles and reduces the sarcopenia. And of course, the muscle mass, strength, and function improves. And when it comes to blood vessels, there is reduced vasoconstriction, reduced LV afterload, and reduced hypertension. It's a vasodilatory effect. So we often see the BP also getting under better control. So respiratory muscles, what it happens as you are breathing faster, the respiratory muscles get stronger. Improved minute ventilation, the amount of air you breathe in a minute improves, and reduced dyspnea. So these effects we often see in the patients with on pulmonary rehab program also. Very effective when it comes to improving their general tolerance. So I was talking about the tele model. No? So tele model, Kaiser Permanente is one of the centers in California, which did a lot of work in tele model. They just provided this BP apparatus and a watch, which is connected to an app, and the doctor gets access to this their values daily. And the nurse would do a weekly once phone call with the patient and make sure that they are compliant with the exercise program. They are taught it can be a hybrid model also, where 3 weeks they come in person and attend the program, followed by a weekly once visits for 2 months, followed by monthly once visit for 6 months. So what they found is that the enrollment rate improved from prior was only 25% of the patients enrolled into the program. After the tele program, it improved to 85% in their case. So graduation rate means the number of patients completing the 36 sessions. So it was 14% before, and it improved to 88% after. So there was a significant improvement in the enrollment and finishing rate. And they found that the outcome is also very much comparable when it compared to the direct program. So that is what they say. But when in our experience with tele rehab model, it's a bit more difficult if the patient is not motivated enough. So if the patient is motivated, it's easier. And of course, we can't utilize the machines which is available in the gym when it's a tele program. So we'll have to rely on the walking or stair climbing or swimming if the patient is swimming prior. So all these are hurdles, and we often ask them to buy a pedal cycle, which is a simple exercise cycle, which is available for like 1,500 rupees online, which is a very good option for in case the patient does not have any hi-fi equipments, and or if the patient is not able to do any hi-fi exercises, just like heart failure patients. It's a good way to start exercising. Pedal cycle. So these are the outcome measures that they looked at. 98% were non-smoking, 47% exercising more than 150 minutes per week. This is one of the outcome measures. They should be exercising more than 150 minutes a week. So 85% maintain low-fat diet. Plant-based diet is a recommendation. At least alternate day, they are recommending patients to become vegetarians. So, and beta blocker compliance. Beta blocker compliance is another outcome measure that they looked at. These are the at the end of the program, they did a study and found that the effects are very similar to the and this is the 6-minute walk test distance in-person program, hybrid program, and virtual alone program. Hybrid model means 3 weeks they will come directly, 3 to 4 weeks, and then followed by a tele model. So that all this had similar outcome. No significant difference between the groups is what they found. So it is a very well accepted thing now abroad. So, and also they looked at the major exercise-related adverse events. That means how many of them had collapsed at home or something like that. They couldn't find very low rates of adverse events because they were getting educated on a home safety program. When you look at the tele model, that is that for that also you will be responsible if the patient collapses at home. So we need to educate the patients on what are the danger signs. So and what to do if you get a danger sign. So usually what we talk about is signs of heart attack. Any pain, pressure or heaviness, especially if it radiates your jaw or back or hand, if it's associated with excessive sweating, dizziness or difficulty in speaking, then you need to stop what you are doing, talk to somebody else, and then have the put the sorbitol below your tongue. And if it doesn't settle in another 5 minutes, you are supposed to call the ambulance. So 10 minutes you can give, 5 minutes. If it doesn't settle, you can put the sorbitol if you have any, and then if it doesn't settle in another 5 minutes, you can call the ambulance. And we also teach patients the basic principles of cardiopulmonary resuscitation when we do the program. So it's a bit scary, especially if the patient is anxious. And some of them take it well and they learn the principles. As of now, we are not providing hands-on education sessions to relatives, but ideally it should be done. At least the hands-on CPR. Uh, and it's very important that the whole team is trained in cardiopulmonary resuscitation and 6 monthly repeat BLS training sessions, and at least one ALS training session should be attended. So now worldwide there is a shift in the outlook from traditional to home-based cardiac rehab program, and the black rim of no cardiac rehab is coming down. So our rehab program can be both outpatient or tele model. So outpatient, our package is for 3 weeks to improve the patient compliance. The idea was that as the cost seems more acceptable and the time seems more acceptable, more patients get enrolled. And it's like alternate, like 3 days a week for 3 weeks, includes the dietitian and nurses visit and the doctor's visit in the beginning and at the end of the program. So even though the doctor's visit is at the beginning and end, most often I go and make sure that they are safe. At least initial 2-3 sessions I do as ECG monitored. If the patient is very stable, only one session ECG monitored. Tele rehab program is for 6 months. This is our program. We have just copied the case of permanente model. So it's the initial visit. We'll meet with the patient and also educate them on the home exercise program and home safety program. Followed by weekly once, we'll provide them a phone call, WhatsApp phone call for 30 minutes and review what they are doing. We provide them an exercise diary to fill their heart rate pre and post exercise to make sure that they are reaching the target level, and also making sure that they're not overdoing or underdoing. More than the heart rate, it's the BOR scale that we look at. BOR scale is the rate of perceived exertion, as you know. What we target is 3 to 4 BOR scale. We start at 2, the slight level of exertion, and 3 to 4 is moderate and sort of hard level of exertion. And exercising in that 3 to 4 BOR for 30 minutes is the final target. There should be warm up and cool down included, and there should be a graded progression. And if they try to overdo in the beginning, you can end up in trouble. So make sure they progress slowly and reach that point. And it's important that we have goals for them. We encourage the patient to set up goals like this should be my target weight and this should be my target cholesterol levels at 3 months, like that. So cardiac rehabilitation is a strongly recommended evidence-based care. It's as important as the medicines that are prescribed for the cardiac problem. And the strength of recommendation by the referring doctor is the decisive factor. So it's important that you convince the referring doctors for this. And 100% uptake is my target in Apollo. So so the acceptance, there are some doctors who made use of this change and referring all their patients to me. There are some doctors who are still reluctant and to send me patients. So it's all their personal this thing. It's a new thing that is coming up in India. Rehab as such is a new thing, I would say, in India, and the awareness among doctors are improving. I won't say we are as bad as like 10 years back. There is more improvement, more centers, especially in Kerala. Now there's a big boom of rehab, I would say, and hopefully in Tamil Nadu also this will come in, and all over India. Thank you. So, so I have a few videos also, sir.
Okay.
I don't know how whether it will work. You can see my screen, no? Can you see my screen?
Yeah.
So I also get good support from this transplant people. They are doing a good amount of transplant rehab, cardiopulmonary and liver transplant surgeons do refer. And this is one of the patients who is awaiting lung transplant. He's on like 12-liter oxygen. And this is a rebreathing mask. And we are doing a 6-minute walk test with the 12-liter oxygen. So they consider this 6-minute walk test as very important factor to determine whether he's a good candidate for surgery and how his outcomes would be. So before surgery, all patients get referred to me for a 6-minute walk test. So we don't have any hi-fi equipments. We don't have CPET machine to assess these patients, because 6-minute walk test is quite simple and just anybody can do it, but it should be done properly. And we should be knowing what all to look for from the 6-minute walk test values. So for this patient, we'll be looking at the oxygen level. So this is an ILD patient, interstitial lung disease. For him, the only treatment available is oxygen. And the medicines are not very effective, and it is a progressive condition which will keep on worsening over time. So he started when we started with him, he could only stand for like 1 minute, and with that he would get a cough precipitated, and even with 10-liter oxygen. We got him for after discharge for a rehab program. Now he is like walking in the treadmill for 15 minutes with the 12-liter oxygen. But as the disease is progressing, he's needing like 15-liter oxygen and all. So hopefully he gets a lung soon.
Lakshmi, please play the video.
This is a very short video, sir.
Okay.
We have the pulse oximeter, we have the oxygen, we have the, this is called an NRBN mask, rebreathing mask. We have the rehab nurse, physiotherapist, and the ward boy. So this is one thing. And this is another patient who had, who was like him before surgery, but he had severe critical illness neuromyopathy after surgery. So after surgery, he was on tracheostomy and very difficult to wean the tracheostomy, BiPAP. So we started doing a spirometry through the tracheostomy. So this is a better spirometer when we compare to the tri-ball spirometry, and our physios have found a connection with the ventilator tubings, with which his capacity is like 250 ml. So usually we target like 100,000 ml. So as he started doing the exercise more frequently, all the muscles improved, and we could wean him off all the supports before discharge. This is him after a few weeks. He's still on BiPAP, but at the time of discharge, he went without BiPAP, and even after removing the tracheostomy. So this is because he had severe critical illness neuromyopathy after transplant. So this is him pre-op. Pre-op means before surgery. Before surgery, this is a ECMO machine. This machine is an ECMO machine. And this machine is Motomed Lecto. This is a very good machine if you can afford it. It's very expensive, but very useful in rehabilitating ICU patients. Motomed Lecto. So the patient can be on the bed and do the cycling. So you can see the saturation and all keeps coming below 89 and all when they exert. Sometimes goes below 70s and all for the ILD patients. So this is a physio looking at the, this machine is a robot. It can do the passive as well as active assisted movements. And when the patient's strength improves, it can do active also. ECMO means it's the heart-lung machine. The patient's lung can't oxygenate the blood. So through this major veins, all this, you can see the tubing full of blood. It is flowing to this machine, and this machine only is oxygenating the blood and returning it back to his body. So this is the VVA ECMO. And on the ECMO, he started doing this exercise pre-op so that we can prevent the muscle deconditioning while he is in the ICU. And this is the same patient with the ECMO. These are all hi-fi things that we do. This is not at all necessary. I'm just showing it to gain your attention, that's all. So this is the ECMO tubing. You can see that it's coming from his jugular vein, and also he has one from the leg, femoral artery. So he's on a tilt table and showing thumbs up. So tilt table standing, as you know, helps to clear out the lung secretions better. So that is why they are all, this is a perfusionist who takes care of the ECMO machine. So and they are all there to help us, and the physios are also very well trained. So in the tilt table, we shifting and all is a big thing, because if any of this cannula comes out, the machine will pump all the blood in his body outside, and he'll immediately die. So it need to be done very carefully. They have strapped the ECMO tubings to his head, and there are similar straps in his thigh.